To this day, we still use the speculum designed and rooted from this man who I won't even like center his name, but all women complain about the speculum. So when people get on their high horse and say, "Oh, um, why are you focused on Black women? These are issues all women face." It's a all woman issue. That's why when you focus on the most marginalized, if we had problems with him performing dehumanizing procedures on Black women and their bodies, we would not now be pedestalizing an instrument that we all have issues with because he would have been deplatformed back then. But because we have an apathy for the suffering and pain of Black women, we all suffer. And until you understand that, we're all going to continue to suffer. When we have these conversations, it's not taking away from anyone's privilege, it's flattening the field to make it more equitable, to make sure every person, every woman is having a human experience when they're navigating these systems.
That was Brenice Duroseau, an infectious disease and addiction medicine nurse practitioner and PhD candidate at Johns Hopkins University. She describes her work as focusing on cisgender Black women around HIV prevention, sexual reproductive health, pleasure, and all things that bring us joy from a sexual reproductive health standpoint. I initially reached out to Brenice after seeing the title of her poster presented at the International Academy of Sex Research on LinkedIn, of all places. And the title of the poster? It's vicious out here. Just keep your legs closed. And no, that's not Brenice's opinion. It's actually a direct quote that Brenice pulled from an Instagram user reacting to Black American singer Tamar Braxton's decision to use PrEP for HIV prevention. The reaction is one steeped in judgment about race, sex, and perceived promiscuity. Welcome to She Really Gets It, a public health podcast. I'm Stephanie Rhodes, a Black woman, public health professional, and your guide to understanding how policies, institutions, and the systems that uphold them harm the public's health, but also how people are coming together to repair that harm and change the system. In this episode of She Really Gets It, Brenice Duroseau and I discuss how a history of dehumanization is not only shortening Black women's lives, but has stigmatized the very idea of Black women experiencing sexual pleasure and what science says we can do about it.
I was reading over your bio, and I noticed one of your long-term professional goals is to improve the lives and sexual reproductive health of Black women globally. What drew you into this world? What made that your mission or one of your long-term goals?
Yeah, so it goes so far back. Um, so in undergrad, I originally was looking to be a pre-med major. I was a bio major with a psych component as well. I wanted to go to school and become an anesthesiologist. It was pretty random. It wasn't really passion driven. And through my time on campus in undergrad many moons ago, I met a wonderful nurse practitioner, Patricia Zapatat, on campus while I was starting a club for students to really get connected with the health center. And through my connection with her and just learning about the nursing framework, I really started to draw a love and a passion for like the nursing model versus like the pure medical model. And since then, like I still graduated because I wasn't about to change my major as a junior and be there for X amount more years. So I graduated and then a year later went back to nursing school instead of medical school. And through that journey, I've always been drawn to women's health. So I did labor and delivery. I did some postpartum work. It's just always been a passion of mine as a woman, as a Haitian woman, as a feminist. It's just the work of women and focusing on women has just always been a passion. So even outside of my professional space, centering women has always been something. And then in this work, as we know with healthcare and in your work with public health, Black women are disproportionately impacted by literally everything. So as I was learning, it's like, oh, higher risk in this, higher. And I'm like, what is going on? Like, why are we literally the poster child for everything bad? Like, this makes no sense. And that is what really drew me into one, research, and also being an advocate, a fierce advocate for centering Black women in things. If we're gonna be used in the statistics to show the disproportionate burden, then I need us to also be overrepresented or represented at least a little bit in the work and in the efforts to, like, change some of these dynamics.
Yes, I've discussed this with other people back when I was doing education with medical doctors and doing a training. We were doing an HIV update, providing training or motivational interviewing training to doctors, basically teaching them how to talk to patients. So we're going through HIV data and data that was specifically like numbers, very straightforward, very black and white, comparing like Black women with HIV prevalence to like white women's HIV prevalence. This white doctor says to me, isn't it true that Black women have higher HIV infection rates because their bodies are different and they respond differently when presented with someone who is HIV positive? And the shock on my face and the shock on his supervisor's face were like, whoa. And it was that inherent bias of like, how did you get this far? How did you get into a residency program? And this was never addressed. And this was never something that was discussed. Or was this discussed and the response was someone confirming your bias, confirming a lie? And you're a doctor that's going out here and you're a white man and you're treating Black women. And I know you have Black patients, which is why I think the work that you're doing is so important. How often have you encountered that level of bias, like just within your field, and how do you address that?
Oh my god, all the time, and it's scary because the training is problematic. Because somewhere along the way, like, that should have been corrected. Because essentially what we're talking about is race science, which has been debunked, and it's not just our white counterparts, there's interracial, like, in-group ideas that perpetuate these, like, race science or misogynistic standpoints as well. So even when having conversations, like, people weaponize the statistics. They hear Black women represent over 50% of the new HIV diagnoses among women. And they're like, oh, well, Black women must be more promiscuous. What is going on with Black women? They must be, IV drug users or like this very fringe situation. And it's like, no, let's talk about the context. Let's talk about the social determinants of health that we love to say, but we don't understand when it comes down to not perpetuating biases. So we have to constantly be checking both and constantly correcting misinformation online, offline, within our colleagues, or the notion that, oh, she's married, she's fine, she doesn't
Yes.
information. So it goes the other way too. Like if I'm in the healthcare system or navigating my own health, providers don't talk to me about HIV or my sexual reproductive health. I have to bring it up because they're like, oh, she's a professional. She's in this space. There's no way. But you don't know what I'm doing on the weekends. I live in Maryland. My zip code alone puts me at an increased vulnerability to, HIV acquisition if I'm dating, if I'm, engaging in sex. You don't know that unless you have the conversation. So it's constant pushback, constant having discussion, and moving away from the individual and looking at these systems because training obviously needs to be revamped because that's egregious.
Yes. And so going back to that thing about the zip code, because I love to talk about that because people want to know. We say social determinants of health, but I think sometimes people in the audience that are listening or people that might be listening to this podcast might say, what does social determinants of health mean? So would you feel comfortable talking about what is an example of a social determinant of health and how that might affect a Black woman's higher risk for HIV?
Yeah, so I like to say social and structural determinants of health. There's literature out there moving away from just the social aspect. So social determinants of health could be things like stigma, for example, how stigma impact one's vulnerabilities. Because with stigma, people say, okay, HIV is just a gay disease. So cisgender heterosexual women don't need to worry about that. But the data shows 92% of HIV acquisition among cisgender women is through heterosexual contact. So that right there, that messaging alone is a social determinant of health that's rooted in stigma. Another aspect of the structural determinants of health are provider bias, provider education, access. So if you live somewhere where the only access you have to HIV prevention or HIV management is a bus in your community, people think, hey, we're bringing the care to them. But you have to think about stigma. You have to think about what that looks like. Yes, it's in proximity, but it's not accessible because of the stigma, because of where it is literally located. So it's things like that are the broader structural social things that needs to be addressed, and not necessarily individual behaviors, because we already know Black women are not quote unquote more promiscuous or IV drug users in some disproportionate amount that's driving this HIV acquisition that we see.
Yes, and the same. I'm glad you brought up the whole thing with like the mobile health clinics, the mobile vans. Because for me, like if I want to get an HIV test and I'm in a rural county, let's say I live in Heidelberg, Mississippi, and it's a rural town, and everyone knows everyone, and they're doing HIV testing. I don't want everyone to know my business, right?
Right. Yeah, exactly. And then when you think about like HIV prevention being siloed into the infectious disease space, which I think is ridiculous, it should be primary care and prevention, OB/GYNs. You're now sending someone to like essentially an HIV or an infectious disease clinic without an infectious disease, knowing there's stigma there. So you're already creating a barrier for people to get into prevention because of where you're locating that service. So it is so many things to unpack. I won't even get into the political determinants of health in this climate, but it's so layered. And until we address those things, we could beat people over the head about their quote unquote behaviors all day. And they're still vulnerable because these larger systems and these structures and how we have things set up increases their vulnerability out the gate.
I'm gonna also just tell anyone who's listening, I found you on LinkedIn because you wrote wanted to make research fun. And so research should be fun. I think research is fun, but I love the poster title. It's vicious out here, just keep your legs closed. And it was in response to Tamar Braxton and her talking about her use of pre-exposure prophylaxis. Was it on TikTok or Instagram?
On TikTok, then reshared on Instagram, and then reshared by the Shade Room. So yeah, that's where I did the analysis.
Can you tell us more about like what you learned from that, what you learned from that data, or rather analyzing people's responses to Tamar's open discussion about her use of pre-exposure prophylaxis for HIV prevention?
Yeah, so it was, the internet is off the chain. So I was already like flabbergasted with this comments alone were just amazing to see. So I originally came up with this idea because I have an amazing mentee. She's in nursing school right now. Wanted to get into research, and I'm always for, more minorities getting into the research phase. So, and she's much younger. So I wanted to connect with her and find a fun project that she could see like all the different ways we could do research and make it important and meaningful. So I was like, social media, the young ones are on social media, they love it. So we went on there in the Shade Room comment and was like, whoa, this is literally a gold mine of information where people might, if you're doing a one-on-one interview, people might not naturally tell you their deep thoughts. They might not jump out with the misogyny and the ageism and the sexism out the gate. I'm a mixed methods researcher. The numbers are important. The numbers are great to capture, but the stories and the words behind the stuff are so important. We pulled all the comments from the comment section. It was like over 3,000 comments. We went through them, analyzed them, and we came up with 4 themes. So there was stigma and judgment. That was over 35% of the comments were stigma and judgment. There was misinformation. That was around like 30%. There was a little bit of support and advocacy. I was like, okay, I could appreciate that. And then there was some questioning and curiosity around like 13%. People did not know what PrEP was. They did not know what it stood for. The misinformation that was really surprising, one of the people in the comment section said their provider told them it was just for the quote unquote gays. And that's something they heard from a provider. They also said, she is outside, so meaning like she's being very promiscuous. A lot of people said she should have stayed with her husband and she wouldn't be in this situation. And from my understanding from the internet gossip, her husband cheated on her. So people are equating her being married versus her being single, as single is the risk factor, not necessarily the infidelity or anything like that within the marriage. There was a lot of ageism about her age, that she's too quote unquote old to be outside. It was just very enlightening to see that even now with all the work that we think we're doing, people still did not know. People were still policing Black women. Purity culture was huge, which is why the title is titled. That was a direct quote. It's vicious out there. Just keep your legs closed. People saying Black women are hypersexual. So feeding into like Jezebel stereotypes that we just cannot not have sex for some reason. So like stripping Black women away from access to pleasure and agency. It was just mind boggling. Like we read all the things, but to see it and to be like a voyeur where people are just doing their things and I'm just observing was just flabbergasting and deeply sad because we have so much work to do.
And it's upsetting because when you think about structural and social determinants of health, what you learn is like Black women are not more promiscuous than white women or any other group of women at all. It's the environment that's different. You're just more likely to come into contact with someone not only who's HIV positive, but who's HIV positive and who is infectious at the time. So someone who's not on medication, which means someone who might not have access to care. And I was talking to a friend about this as well. I feel like when I was a kid, we were constantly talking about HIV. I would see commercials about HIV prevention. And maybe it's because I don't watch real TV anymore. I feel like I don't see that anymore. I don't see like commercials about condom use or, anything. Have you noticed that, or do you have any opinion on that or thoughts about that?
Yeah, no, that's a good point. When we talk about HIV prevention in particular, we always talk about PrEP, but treatment is HIV prevention as well from a public health standpoint. The more your community viral load is suppressed, the less likely people are going to be acquiring HIV. So that's a huge part of the conversation that always gets missed. And I'm guilty of it, being a champion for PrEPs, because there's so many challenges to getting someone undetectable and sustained undetectable, because life happens, all the social structural stuff. And then to your point about marketing, we have to do better with marketing. With a subscription world due to capitalism, people barely watch live TV anymore. We have the Hulu's, the Netflix, the recording and then watch later, all these other things. But even though people, the ones who do have access to commercials, in my dissertation work, which is a paper coming out, women are confused because there's Descovy for PrEP, which has not been studied among cisgender women to show vaginal uptake of protection for HIV prevention. So in the commercials, it says not for cisgender women, instead of not for those having vaginal sex. So because of that, people take that and say PrEP is not for women. So in my dissertation during interviews, people are saying, oh, even in the commercials, it says it's not for women. And I'm like, oh, there's misinformation being perpetuated because of how some of the marketing is. If they had other commercials with Truvada, with, now lenacapavir, with Apretude, where they see themselves, everyday women like us just hanging out, having a cup of coffee, saying, hey, girl, I'm going on a date next week. And, I just got my lenacapavir injection, my second, injection for the year. I'm good to go. It would resonate more with people that, hey, this is just normal.
So let's talk about PrEP, specifically like the different options. So I know there are different types of PrEP. So there's PrEP for HIV prevention. There's also PrEP for other STIs. So PrEP for HIV prevention, which is pre-exposure prophylaxis, and it is different for cisgendered men and trans women versus cisgendered women and trans men in terms of how long it takes for it to become effective, correct? And so for cisgendered women, what are the options for pre-exposure prophylaxis?
Yeah, and I love that you mentioned the confusion because I hear this all the time. And so when I'm talking to women, I like to compare it to birth control because that's something that we've been exposed to, whether we've taken it or not, since we were in middle school. So pre-exposure is kind of like taking the birth control pill every day, for preventing pregnancy. PEP, post-exposure, is like taking a Plan B pill. Within 72 hours, and you don't know, you don't know what happened, you don't know if you had exposure to, semen or not, but you want to make sure you don't end up pregnant. That is the comparison I like to make so people could to kind of understand it. So the options for women, cisgender women, which we love to have options because the more options you have, the more tools you have to make decisions as to what fits your lifestyle. So there's Truvada. It's approved for women, including cisgender women. This has been approved since 2012. It's always been approved for cisgender women. It's not new for women. It's just the marketing early on really centered around men that have sex with men, but it is for cisgender women. Then there's Apretude. It's an injectable that you take every quarter, and that's highly effective as well. And it also is inclusive of cisgender women. Then there's lenacapavir, which was literally just FDA approved in June, I believe, and is twice a year injectable for HIV prevention. Also inclusive of cisgender women, was studied first among Black cisgender women. We were thought of initially, which is correcting a lot of the wrongs that have been done historically. So like we were really central in this drug being developed and in the ideas and the design and the promotion of this medication. And then when you talk about the uptake, so for Truvada, it's a pill you take every single day, which some people prefer a pill. They don't want to do injections. They're scared of needles. They rather a pill is in the forefront of their mind. They don't want something in their system for a period of time. So that you take every day. But for women in the vaginal tissue, it takes 21 days for it to be absorbed within the vaginal tissue for efficacy, about 21 days. For males on the rectal tissue and stuff, it's about 7 days. So biologically, there's already a difference. That is also a barrier. So women need to understand that. They need to use alternative methods for HIV prevention in particular during that 21-day period when they're just starting out for Truvada. And for our trans women, there's also Descovy. It's also a pill, but it is not approved for receptive vaginal sex. That's where some of the confusion comes in.
And side effects and drug interactions are also a concern, to which Brenice stated,
Yeah, so like with side effects and drug interactions, I would say have the conversation with your provider. There's so many, different things, but like for the oral pill, for example, there's very minimal drug to drug interactions. There are a couple things, just to be concerned about or just to be mindful of. Let's say like you have like kidney issues, for example, before you're even on this medication, there's conversations that need to be had. If you're on certain different medications, there's conversations that need to be had. But all those things are conversations you should have with your provider. I hate to just have like the broad conversation around it because then people think, oh, it can't be for me. Where there's like different things you could do as a provider, like, oh, somebody's on this medication, you could potentially get that medication switched because it's not like that serious or that it shouldn't be that much of a barrier. Or someone's taking something, what you call it, like over the counter that, they may not even necessarily need. You could have that conversation. So like there's things like that, but there's very minimal drug to drug interactions. There's very minimal side effects. It's pretty well tolerable. Some of the GI stuff like upset stomach, people may have, that's still a small percentage of people that have that. And then even those who experience that, it usually resolves. But I always encourage people, it's a medication. Have the conversations with your provider. See what works for you, what doesn't work for you, what fits your life, what doesn't fit your life, and go from there. It's As far as a side effect and, drug-drug interaction standpoint, there's a PrEP option for most people, I would say. Like, it has not been an issue that I've seen clinically.
At this point, we shifted the focus of our conversation to discuss a phenomenon that the general public may not be aware of, and that is the intersection of domestic violence and interpersonal violence, also known as IPV, and HIV prevention. As a public health professional, I have seen firsthand how interpersonal violence, or IPV, and domestic violence can thwart common methods for HIV prevention, such as condom use.
Yeah, no, I love that you bring up the point about ITV because, first of all, PrEP should be included in safety planning for ITV survivors or people navigating ITV because it's a huge component. Over 50% of non Hispanic Black women report a lifetime contact of either some form of sexual violence, physical violence, or stalking by an intimate partner. So when people be like, oh, well, why Black women? It should be all women. Yes, all women will benefit from these things, but it's important to have the conversation because Black women are disproportionately impacted by IPV. So even something as condom negotiation, making sure the condom actually stays on during the entire sexual encounter. People are stealthing people, removing condoms, reproductive coercion is a thing. It's important to have tools in their tool belt. So I always say PrEP is an empowerment tool. It's a form of justice and a form of like having access to something that you otherwise would not be able to 100% protect yourself with. From a feminist standpoint, anything a woman has control and agency over when it comes to her own body, the better. When it comes to condoms, yes, there's female condoms, but they're used less often than male condoms. You have to trust that it's on correctly. Everybody is not fit for a magnum. There's so many things to think about, and I can't imagine trying to enjoy an experience where I have to think of like 50 million different things. Whereas if I'm on PrEP, I know there's 99% chance of not getting HIV. That's one less thing off the table in all the things you have to worry about as women, especially when we're already talking about an orgasm gap. And I think if we reframe the conversation around our pleasure, around our peace of mind, around maintaining our edges, I think the conversation could be a little bit less scary and burdensome to where, okay, this is just like me having another thing in my bag to where I'm protected, I'm safe. And like an injectable, it's out of sight, out of mind. I get the injection twice a year with lenacapavir, and I don't even have to think about this anymore. I'm not worried about this. And, there's nuances because if you're experiencing a violent relationship, can you get to the clinic? Maybe, maybe not. Is he going to be there watching you? Because it's not something you could take at home. Those are nuances and conversations that we need to have, especially from a structural standpoint. So a pill might be the only thing they can access at home, hide it, and take. So, but there's options. And that's the important thing because we need to figure out what fits within the lives and the circumstances that women are navigating.
Now, for someone like myself or Bernice, who have spent years working in HIV prevention and education, we know that HIV does not discriminate, and therefore, HIV prevention is for everybody. Unfortunately, stigma, homophobia, and transphobia has influenced not only the general population, but even healthcare providers and the institutions that train them.
And that's another thing, non-gay men aren't part of the conversation. That's why even language is important. Men who have sex with men versus gay men are two different, things in like the real world. So it's important to have these conversations. And to be fair, it's again part of the training. A lot of the new information that comes out, like lenacapavir coming out, I know this because I'm in infectious disease. All my continuing education credits are focused on infectious disease. I do research in this space. But if I'm a cardiologist, That's not the continuing education I'm doing. That's not the training I'm focused on. If I'm a primary care provider, that's not necessarily the work that I'm doing. American Academy of HIV Medicine has programs for, primary care providers, pharmacists who want to get more information about HIV, but that has to be a desire or an interest. We need to do better in generalizing this information so providers know, so patients can know. There was a study that came out because some providers think, oh, if the patient needs or have these sexual reproductive health concerns, they'll bring it up to me. But no, there's a study that came out that showed, I think 40 to 60% of women said they want their providers to have these conversations around sexual health. They leave it up to them. And if they don't bring it up, they're not going to start this conversation. So we understand our power in the hierarchy of like provider patient relationships when it comes to other things, but we seem to fall short when it comes to sexual reproductive health. And a lot of that is, the misogyny and sexism in medicine.
Now, a lot of healthcare providers may still feel uncomfortable bringing up HIV testing and doing so in a way that doesn't make their patients feel uncomfortable. So, how do you do that?
It's how you frame it. I rarely have patients turn down HIV tests because that's how I frame it. I said, hey, today we're ordering this, that is included. Like I say, we're ordering your CBC, we're ordering this, we're ordering that, we're ordering HIV, chlamydia, gonorrhea, syphilis. Do you have any questions? That like it's this is what we do. This is what we do for all patients. This is what we do at each follow-up. And they're like, oh, okay, I never had an HIV test or no one told me about that. I'm like, oh yeah, this is just standard. It's always been the gold standard. I'm sorry that you have not experienced that. You'll make it abnormal that they had not had an HIV test before because guidelines say anyone between 13 and 65 should have had at least one. And then if you're sexually active, it's part of your preventative standard healthcare. So why not? You're paying insurance. Why not get the care that you deserve? So it's how you frame it. And then even for like elderly folks, I'd be offended if now all of a sudden, because I'm 65 and finally have time and now I'm not a sexual being anymore. Like how rude. And I could get the anxiety as a clinician when I was like way younger, starting out in my hometown. So some of my patients were some of my church lady friends having the conversation about sex. And there's an age dynamic, but I had to get over that. I had to learn how can I talk to them. I said, girl, I know you're in the church. So am I. But this is just something I offer to all my patients. So I just normalize it. So we don't have that weird awkwardness that like church hat lady and me in my 20s having conversations around how she get down on a Saturday before the pulpit on Sunday. Especially when you're not concerned about getting pregnant anymore. You're like, oh, okay, I'm not getting pregnant, that could go, and then if you're thinking about like erectile dysfunction, some of the things like some of the older men may deal with, putting on a condom may delay that ability to like maintain that erection. There's so many things when you think about the anatomy of women and postmenopausal and vaginal dryness that could potentially increase your vulnerability because if you have dryness and you're tearing a little bit during sexual intercourse, those are sites of potential, infection acquisition. So there's so many things where we drop the ball on handling people's menopause. So make sure they can have pleasurable and safe sex. Having these conversations around condoms or not condoms. Oh, there's so many things. And Dorcas Baker here at Hopkins does an amazing job trying to normalize the conversation with HIV and aging. And I love that because it's such a missed opportunity.
At this point, we continue to discuss how living at the intersection of ageism, sexism, and racism further increases the risk for HIV and other STIs, and why this must be addressed to prevent HIV.
Like outside of our reproductive years, we're like forgotten and tossed away because women, their value is in their ability to reproduce. That's why women who navigate infertility are chastised in society. So it's really deep when people think like, oh, here she goes again with the feminist stuff. It's ingrained in our society and how women are treated, how women are cared for, how women survive. Like it's literally a matter of survival. Women are dying because of sexism and misogyny, because it's systemic. To this day, we still use the speculum designed and rooted from both man, who I won't even like center his name, but all women complain about the speculum. So when people get on their high horse and say, "Oh, um, why are you focused on Black women? These are issues all women face." It's a all woman issue. That's why when you focus on the most marginalized, if we had problems with him performing dehumanizing procedures on Black women and their bodies, we would not now be pedestalizing an instrument that we all have issues with because he would have been deplatformed back then. But because we have an apathy for the suffering and pain of Black women, we all suffer. And until you understand that, we're all going to continue to suffer. When we have these conversations, it's not taking away from anyone's privilege, it's flattening the field to make it more equitable, to make sure every person, every woman is having a human experience when they're navigating these systems. And that, I think it's a hard pill for people who have benefited from these in their minds because they have not connected the discomforts of their lives to these things. So in their minds, they think they have benefited and have been coaxing the world in such a way until it hits home and they're like, oh, I did not realize these things were connected. I mean, it's unfortunate that it needs to be at your front door for you to have that level of empathy. But I mean, however we need to get there, we need to get there. Even in the conversation around HIV prevention for so long, just from like a clinical lens, it was always the fear standpoint. Oh, let's prevent this, let's prevent that. And then, one of my mentors, Dr. Shamika Thorpe down at University of Kentucky, love her down. She does pleasure work, sexual pleasure, and she absolutely does not do HIV prevention from like a deficit lens. And just working with her, just talking about like sexual pain, overcoming certain things, like the joy in sex, and where does HIV prevention fit within that, like completely like changes the conversation, because not everyone wants to have the deficit based conversation all the time. It's off-putting. It could cause sexual dysfunction because it creates anxiety, even just the fear around, oh, these men are, trifling or this and that and the third. That's why I need to be on PrEP. How about, hey, I'm empowered. I'm powerful, just like I could pick and choose when I have a baby. I could pick and choose what I'm exposed to. And that's something that I'm going to say I don't want to be exposed to. So I'm going to be on this. I have access to this. Like reframing it and like, how we're navigating the world. I think this is so incredibly important. And like you said, the conversations and the storytelling. Every time I hear a story, especially in academia, especially in clinical world, oftentimes it's from a white lens. And like, I always have to say, okay, what voice is missing here? What experience is missing here? Because it's a lane that is usually steeped in privilege, steeped in different things, and you have blinders. Even I have blinders. Like, that is why my dissertation work was only including Black women. A lot of studies have comparison groups, like you're comparing Black women to white women, Black women to Hispanic women. There's importances there when you're looking at like disproportionate rates, who's most impacted. That's important to have all the who's to know who's most impacted. But when we're understanding the day-to-day lives and the stuff, we need to do within group differences. We are not a monolith. There, the roundaway Black girl, the corporate baddie, all these, there's so many different stuff, and it could connect us. It could show like parts where we diverge, all these different things, but we don't know that. We're always comparing ourselves to other people. We don't get to understand the nuances. And I think it's so important to do that within group work to really understand who among us, what are we navigating? What are the similarities that we're navigating? Because studies show, even with maternal mortality, education and socioeconomic status are not protective in the same way for Black women. So you would think, oh, you just need to be educated and have money, and you're not going to deal with this. But yet we see Serena Williams and Beyonce talking about their near-death experiences, bringing children into this world. So that is an opportunity to say, well, what is going on here? It's the systems, it's the racism, it's the not listening to Black women's voices, regardless of where you fall on the hierarchy of capitalism.
If you would like to learn more about Brenice's work, you can find her on LinkedIn with her name, Brenice Duroseau, and as the NP That Cares on all social media platforms. If you want to read the scientific literature she has authored, you can do so via Google Scholar by simply searching her name, Brenice Duroseau, FNP-C. I'll put links for all of her contacts in the show notes. If you are interested in utilizing pre-exposure prophylaxis or PrEP for HIV prevention, you can find a list of providers in your area via the PrEP locator at preplocator.org. You can also learn more about PrEP and other HIV prevention tools at www.healthysexuals.com. If you are a provider who wants to learn more about HIV prevention and how to discuss PrEP with your patients, please check out talkprep.com. And if you are a nurse that is interested in advancing your expertise in any dimension of HIV disease, you can check out ANAC, A-N-A-C, the Association of Nurses in AIDS Care, at nursesinaidescare.org. And if you enjoyed this episode of She Really Gets It, please review and rate this podcast via Apple, Spotify, or wherever else you get your podcasts. It really helps people find the show. If you have any topics you believe we should explore on future episodes, you can join my Substack and reply to any of the emails I send out. Links to that will also be in the show notes.